Chapter 26, Digestive System, Part 1, Screencast 2. Now, this screencast will be focusing on all of the structures found in the upper GI except for the stomach. That will be covered in the next screencast. If we look at the structures, we basically look at the oral cavity and salivary glands, the pharynx, the esophagus, and the stomach. Now, our text considers the duodenum, which is the first part of the small intestine, to be part of the upper GI tract. I understand why they do so, but I do not like splitting organs, and we will further address the duodenum in the second part, which is focusing on the lower GI. Now, one of the things that I want you to be comfortable with is what foodstuffs are digested where and where it begins. Now, if we look at the oral cavity and then the salivary glands, this is where mechanical digestion begins. Now, we also have saliva, and this is coming from the salivary glands, and this is response to food in the mouth. And primarily, we will see salivary amylase, and that is an enzyme that is responsible for beginning the process of starch digestion. Now, the other thing that's happening with the oral cavity is foodstuff will be mixed with ingested materials and secretions, and that actually forms the bolus. The pharynx is responsible for moving the bolus down towards through the esophagus and to the stomach. We'll also see mucus as being secreted here to facilitate the swallowing process. The esophagus, this is a muscular tube, and the bolus will be moving from the pharynx into the stomach. This also will be aided by mucus secretions. The stomach, actually, the bolus becomes mixed with gastric secretions, and this is due to smooth muscle contractions of the 3 layers of the smooth muscle found within the stomach. Also, there are quite a few secretions that are produced by the epithelial cells of the stomach. The product of this is known as chyme, and chyme is actually what will move into the small intestine for further digestion. Now, here we see an image of the oral cavity, and it's not my intention to spend a lot of time or focus on either the oral cavity or teeth. Unsurprisingly, the histology is stratified squamous epithelial tissue because this is an area where there is mechanical stress. The majority of this stratified tissue is non-keratinized. There is some keratinized type which lines the lips, portions of the tongue, and a small region of the hard palate. Now here we're basically looking at a sagittal section of the oral cavity and the pharynx. And note, we have addressed some of these structures previously because remember, the pharynx is actually shared with the respiratory system. So once again, we've covered a lot of this previously, but the emphasis now will be on the structures of the oral cavity primarily, as the pharynx has been previously addressed. Now, there are 2 types of salivary glands. There are going to be intrinsic salivary glands, and these are small glands that are referred to as unicellular, and they are continuously releasing their secretions whether or not food is present. They contain something known as lingual lipase, and this is not something that I refer to in a great extent because, once again, what happens, this actually starts to become less of an issue as we get older. So as we get older, we'll be producing less of this lingual lipase, and it makes sense that we see a lot of lingual lipase activity in infants because their primary food source will be breast milk. What we will put an emphasis on are the salivary glands that we refer to as extrinsic, and they are the ones that produce the majority of all saliva, and they are the parotid, the submandibular, and the sublingual glands. Now, the parotid salivary glands, they are the largest. They are anterior and inferior to the ear. They produce anywhere from 20 to 30% of total saliva, and this saliva is actually conducted to the oral cavity via the parotid duct. It extends from gland across the masseter, the opening near second upper molar. Some individuals, when they have this gland infected, it is known as the mumps. Submandibular salivary glands, they produce the greatest amount of saliva, from 60 to 70%. They are inferior to the oral cavity floor and medial to the mandible body. The submandibular duct opens from each gland to the floor of the oral cavity. The last set are the sublingual salivary glands. They are inferior to the tongue and medial and anterior to the submandibular glands. They have these tiny ducts that extend into the inferior surface of the oral cavity. These contribute only 3 to 5% of total saliva production. So a question might ask is basically put these in the order in which they secrete the most to the least amount of saliva. So that would be the parotid, the submandibular, then the parotid salivary glands, and last but not least, the sublingual. So once again, submandibular produce the greatest amount of saliva, the parotid are second, and then the sublingual salivary glands actually produce the least amount of saliva. Now, when we look at saliva, typically 1 to 1.5 liters are secreted daily. The majority of this is during our meal times. Most of saliva is water and accounts for 99.5% of salivary contents, but there are some other solutes. Examples would be salivary amylase, mucin, and there's lysozyme. Now, the functions of saliva are to actually add moisture to foods that we have ingested and to aid in the process of that food becoming a bolus. Salivary amylase, that's actually going to initiate the breakdown of starch. Notice this is an enzyme, so we are referring to chemical digestion of starch. Food molecules will be dissolved as part of the chewing process, so taste receptors are stimulated. Also, saliva will be cleansing oral cavity structure, and there are antibacterial substances that inhibit bacterial growth that are also components of saliva. Now, when we look at mechanical digestion, that is actually going to be mastication or chewing. This is when we mechanically reduce the bulk of food to facilitate the swallowing process. It increases the surface area so that enzymes can be more exposed to the food. It will promote salivation, but this is a very coordinated activity, and there's actually a center in the medulla and the pons known as the mastication center. So mastication is actually a relatively complex movement that involves the coordinated activity of our teeth, lips, tongue, cheeks, and jaws. Now, also, medications that are made up of small nonpolar molecules. The best example I can give you is nitroglycerin. That can actually be placed under the tongue where they pass through the epithelium through simple diffusion. Keep in mind what nitroglycerin is used is in cardiac patients that are prone to chest pain. The nitroglycerin is a very potent vasodilator that actually dilates the coronary arteries, and basically that will relieve chest pain. Now, I don't spend much time focusing on the teeth at all, so you can actually just review this, but it's not my intention to cover teeth on the exam. And the same thing here. Now, the pharynx and esophagus. Now, remember, the pharynx is a funnel-shaped muscular passageway, and it kind of makes sense that it's a funnel. It's going to make sure that food moves into the esophagus. Now remember, the pharynx is a passageway for both air and food, and typically we see 3 pairs of skeletal muscle: superior, middle, and inferior pharyngeal constrictors. So these are under voluntary control, and so we can actually use them when we physically swallow or control swallowing. Unsurprisingly, the pharynx is going to be lined with non-keratinized stratified squamous epithelium, because the pharynx is an area where there could be mechanical stress. Now, generally, the esophagus is a collapsed tubular passageway. It begins at the level of the cricoid cartilage. It is directly anterior to the vertebral bodies, and it is the inferior region of the esophagus that actually connects to the stomach. Now, the esophagus will move through an opening in the diaphragm known as the esophageal hiatus, And there is some esophagus that actually makes its way about 1.5 centimeters within the abdomen before it actually meets the stomach. Now, there are two sphincters. We have the superior esophageal sphincter, and this is a contracted ring of circular skeletal muscle at the superior end of the esophagus. This is where the esophagus and the pharynx actually meet. Now, this sphincter is closed during the inhalation of air. Now, we also have the inferior esophageal sphincter, and this is a sphincter that goes under multiple names. You may hear it as the gastroesophageal sphincter. You may hear it as a cardiac sphincter. All of those are accepted names. Now, this is actually a ring of circular skeletal muscle at the inferior end of the esophagus. Now, keep in mind that when this sphincter contracts, it is not strong enough on its own to prevent stomach contents, which are acidic, from regurgitating back into the esophagus. The diaphragm is something that does aid in this function. Now, if we look at the histology, the esophagus is lined with non-keratinized stratified squamous epithelium because it also is under mechanical stress. Within the submucosa, this is thick with lots of elastic fibers, and this allows for distension during swallowing. There are going to be numerous glands that are providing mucus, and here mucus is actually acting as a lubricant. Now, if we look at the muscularis, this is a little different because there is both skeletal and smooth muscle. There are 2 layers of skeletal muscle in the superior third, and this makes sure materials move rapidly out of the pharynx. Now, the skeletal muscle becomes intermingled with smooth muscle in the middle third, and by the time you get to the inferior end of the esophagus, it is entirely smooth muscle. Now, there are 3 phases that are involved in swallowing, which is also known as deglutition. Now, this is the moving of ingested cavities from the oral cavity to the stomach. There is a voluntary phase. This actually occurs after ingestion, and this actually involves the cerebral cortex. Now, remember, the bolus will be formed as food that we consume is actually mixed with saliva, and it's going to be pushed back towards the oral pharynx. Then we have the pharyngeal phase. At this point, both the soft palate and the uvula, they close off the nasopharynx, and the larynx also elevates so that the epiglottis closes. Then there's the esophageal phase. This is when the soft palate, uvula, and epiglottis return to starting position. At this point, the superior esophageal sphincter closes. The bolus passes through the esophagus on its way to the stomach. So keep in mind, we have the voluntary phase, but then the pharyngeal and esophageal phase, they're not voluntary. Now, many of you probably experience gastroesophageal reflux disease, or GERD, and this is due to inflammation of the esophagus from the acidic chyme that makes its way back into the esophagus. Generally, this appears as pain posterior to the sternum, so quite often it's called heartburn. Generally, we will see this in individuals that are overweight, smokers, and after large meals. Also, it may be seen in individuals that have what's known as a hiatal hernia. This is when a portion of the stomach is actually protruding through the diaphragm. Now, the treatment is going to be lifestyle changes, head elevation, and limiting the size of meals. Now, we can also see that this results from reflux esophagitis, and there is an erosion of esophageal tissue. And then there might be this buildup of scar tissue that results in a narrowed lumen. Now, one of the things to be concerned with is we might see a change from stratified squamous to columnar secretory epithelial tissue. This is known as Barrett esophagus. And the problem here is that this condition increases the risk of cancerous growth. We are starting to see more individuals present with esophageal cancer. Now, this is a condition that can actually be treated with multiple medications. Many are proton pump inhibitors and also histamine blockers.